and she's going to tell you why it hurts you and where. Dr. Zuckerman.
Hi everyone. Thank you very much for coming, especially with rainy weather. I appreciate your being here. The way I would like to structure the presentation tonight is like this. I was here 5 years ago, and at the time I focused my talk on distinguishing between osteoarthritis versus rheumatoid arthritis, which are the two classic examples of non-inflammatory degenerative arthritis versus autoimmune inflammatory arthritis. And then we talked a lot about gout last time as well. So I don't know if any of you were here 5 years ago. I was thinking that since some of you might remember something from then maybe, that I would switch it up a little bit tonight and focus my talk tonight about common causes of soft tissue pain in rheumatology. The microphone is whining a little bit. Is there any way to...
Just keep talking, I'm trying to fix it.
Keep talking?
Hey,
I think the microphone has joint pain. Okay, so I wanted to focus my talk tonight on some common causes of musculoskeletal soft tissue, like soft tissue pain, or what we call soft tissue rheumatism. So I'm going to go through my presentation, but I also brought my slides from 5 years ago that go more into osteoarthritis and rheumatoid arthritis, and if time allows and there's interest, I can go over some of that stuff too. We can, and hopefully we'll leave time for questions. All right, so with that, let's get started. So, common causes of musculoskeletal pain. So, as I said, my goal is to review common causes of regional musculoskeletal pain. So when I say regional musculoskeletal pain, I'm implying that there isn't a systemic disease per se that's caused it. It's more, a local, regional problem as opposed to a systemic problem. And within that conversation, I want to just point out that I'm not going to address fractures as a cause of pain. Let's just kind of put it out there that fractures cause musculoskeletal pain. Also, osteonecrosis is something that can cause regional musculoskeletal pain, but I'm not going to cover that. Osteoarthritis I can touch on, but it's not going to be the focus of my talk, as I said. Infections can cause pain, rheumatoid arthritis and gout as well are not going to be the focus of my talk because we covered that last time, but I'll try to allude to it when it's relevant. Okay, so let's get started. So I'm going to go by region. We'll start from the shoulders and move our way down. So shoulder pain. In this slide, I listed some common causes of shoulder pain, the most common being a rotator cuff injury, and we'll talk about that the most. But just to point out that a labral tear can cause shoulder pain. Adhesive capsulitis, or another name for that is frozen shoulder. It might be the name that you're more familiar with. Biceps tendinopathy or rupture, and osteoarthritis we'll touch on. So I want to start with just looking at the shoulder anatomy by way of introduction. So up here, let's see if this pointer works. Okay, great. It's not as clear as I was hoping, but what I want to point out is here's your shoulder joint. That's the humerus bone. That's the scapula. That's the clavicle up here. And this bone wraps around from the scapula to meet the clavicle at the acromioclavicular joint. This is the actual shoulder joint itself, where the humerus articulates with the scapula. That's your actual shoulder joint. But all of these structures can cause what we would call shoulder pain, even if it's not true shoulder joint pain. So starting with, so let's just kind of run through this list and just describe where is the origin of the pain anatomically. Starting with the rotator cuff injury. Actually, let's advance the slide for a minute. Because here you can see the rotator cuff a little bit better. All of you have heard of rotator cuff tears or rotator cuff tendinopathies. Probably many of you actually have experienced it for yourself. So let's understand better, what is the rotator cuff? Oops. Okay. So the rotator cuff is made up of the tendons of 4 muscles that control the shoulder movement, and those 4 muscles are called the supraspinatus, the infraspinatus, the subscapularis, and the teres minor. And those four muscles are found here. So this is your supraspinatus up here. This is the supraspinatus from the back. So here you're looking at it from the back, and here you're looking at it from the front. This is the infraspinatus, this is the teres minor, and then looking from the front on the inside of your shoulder blade, that's the subscapularis. All of these muscles have tendons, and those tendons attach on the shoulder. So if you look over here on the shoulder, there's the tendon inserting there. Here are some tendons inserting on the back of the shoulder, and here the subscapularis that inserts on the front of the shoulder. So collectively, the tendons of those four muscles collectively are called the rotator cuff because they help us to rotate the shoulder. They're responsible for shoulder movements that abduct the shoulder, internally and externally rotate the shoulder. So we call that collectively the rotator cuff. Going back now, just to touch on some of the other anatomic landmarks. Here you're looking at the shoulder sort of. Here you're looking at it from the front. Here you're looking at it from the side, and you don't see the entire shoulder joint. You're looking at the articulation of where the humeral head, the head of the humerus, would articulate with the scapula. That's where you're looking at it, and here's a blown up picture. And what you can see is that it's kind of like we call it a fossa. It's like a concave place where the head of the humerus can articulate, and surrounding it is a ridge called the labrum. So when someone gets a tear over here, that's called the labral tear. Adhesive capsulitis basically refers to all the soft tissues that articulate on the shoulder. We'll get into that in more detail a little bit later, so I'm not going to dwell on it right now. Biceps tendinopathy refers to this biceps tendon over here that inserts in the front of the shoulder, and when that tendon becomes inflamed, it can cause pain. We call that biceps tendinopathy, or it can tear or rupture. That's even worse. And then osteoarthritis has to do with degenerative changes inside the joint itself. There are two joints in the shoulder that can be affected. The actual shoulder joint, we call that the glenohumeral joint because it's where the humerus articulates with the glenoid fossa over here. And then the other shoulder joint that can be involved is called the acromioclavicular joint, and that's this joint up here that joins the clavicle to the acromion process. So there's actually two joints in the shoulder that can have degenerative arthritis that we call osteoarthritis. So there are a couple of these that I want to just talk about more in detail because they're the most common. So going back to the rotator cuff. So we talked about which structures are involved. Out of all the rotator cuff muscles, the one that gets involved the most is the supraspinatus, and that's this one. I have to practice with the pointer. That's this one up here, and you see it up here as well. And if you look at if you look at the anatomy, it's easy to understand why this one can cause trouble. So this one comes up here, and then the tendon runs under the acromion over here, and then between this head of the humerus and the acromion up here, this tendon kind of has to run and then attach like right here. So you can see that that's a danger zone for getting pinched, right? If you can kind of imagine that this muscle shortens and then abducts your arm, and as you abduct your arm, the humerus gets closer to the acromion, and you can picture how that tendon can get pinched over there, and so it can get pinched, it can swell, and it can tear, and that's why it's the most common place to get a problem with your rotator cuff. So what causes it? Basically, any repetitive overhead reaching, pushing, or lifting with outstretched arms. People who are involved in the sports that are listed there are particularly at risk, but this can really happen to anyone. It doesn't have to be people who play sports. And basically, you'll feel pain where that tendon is getting pinched. So at the edge of the shoulder and in this region over here. It's aggravated though when you do activities that basically elevate the arm. Anything that brings the arm over 90 degrees can tend to aggravate that pain. Okay. And it can get pretty bad. I mean, it can happen with activity when it's you know, early, but if it's, you know, really inflamed, then it can hurt all the time, and when you lie on your shoulder at night, it can really bother you. And tendinitis, you know, you'll see that this is a recurrent theme in the talk tonight. Most the approach to tendinitis tends to kind of be more or less across the board for most tendon inflammation, which is that you have to rest, you have to stop doing the aggravating activities as much as possible within your activities of daily living. You can use anti-inflammatory medications. We call them NSAIDs, for non-steroidal anti-inflammatory drugs, and they include common medications that we all know, like ibuprofen, naproxen, diclofenac, meloxicam. Those are medicines that are both have a pain-relieving property, but also have an anti-inflammatory property, and so we use them to treat tendinitis. We can also use other modalities like ice and physical therapy. That's usually how we approach the rotator cuff tendinopathies. So that's to distinguish between a rotator cuff tendinopathy from a rotator cuff tear. So usually a rotator cuff tear is sort of the long-term result of a chronic rotator cuff tendinopathy. When a tendon is chronically inflamed, and you know, it's very hard to completely not use your arm. So you know, unfortunately, even when the tendon is inflamed, we continue to use it as much as possible, I guess, and then it can get further injured. And when you have a chronic inflammation that doesn't have adequate opportunity to heal, you can start to get small tears, and then you can get larger tears, and you can even have a complete tear. The way we distinguish that, it's not always easy, that's the truth, to tell clinically whether a person has a rotator cuff tendinopathy, which means that the tendon is swollen and angry but not torn, or whether there's a tear. It isn't always easy. One of the tips, though, is that, you know, in rotator cuff tendinopathy, usually the strength is intact. So even though it might hurt to pick up the shoulder or to move the shoulder, the person can do it. It just hurts. In a rotator cuff tear, the tendon is not attached to where it needs to be attached anymore, and so you might see weakness, like the person really can't elevate their arm anymore. So that's one tip-off. But you know, sometimes when pain is so severe, pain can mimic weakness because the person doesn't want to push through the pain, so it can come across to the clinician as weakness. So I've read that some people might inject lidocaine to see if, like, eliminating the pain from the picture can show them whether or not, you know, then the pain goes away, whether there's true weakness there. But I don't think that that's done so routinely. What's normally done is that you give the person a trial. If it's very apparent that it's weak, you know, then you can go for an MRI, and there are certain situations where you would operate on a torn rotator cuff. But usually it's not a full tear, and sometimes when it is a full tear, you still approach it with what we call conservative management. So often what will happen is, you know, you start with physical therapy, anti-inflammatory drugs, ice, sometimes a corticosteroid injection, and if the person doesn't respond, then you know, on follow-up, the doctor might order an MRI to assess, is it just a tendinopathy or a tendinitis, or is there actually a tear there, and then you might refer to orthopedics for consideration of surgical repair. Okay, so adhesive capsulitis or frozen shoulder is a little bit different. It might involve some of the same structures, but rather than it just being that the tendon is inflamed, the inflammation that it could be also sort of what we call the sequela of a chronic rotator cuff tendinopathy. But basically any injury to the shoulder, whether it's a chronic rotator cuff problem or whether the person has had a shoulder fracture or a shoulder surgery, any situation that might cause chronic inflammation to the soft tissue structures of the shoulder might kind of lead to this common endpoint of a frozen shoulder. And the hallmark of a frozen shoulder is that it really doesn't move, and it doesn't not move because the muscle is too weak to elevate the shoulder. It doesn't move because it's really stiff. So frozen shoulder basically refers to a situation of scarring in the soft tissue of the shoulder that makes it very stiff, and unfortunately the person loses range of motion in their shoulder. Now it can be accompanied by pain, but it doesn't have to be. The main hallmark is really basically the loss of motion in the shoulder. So there are, in addition to shoulder injury, there are people who are more at risk for this to happen to them. So I listed some of the risk factors. Prolonged immobilization of the shoulder can cause stiffening and scarring. People with diabetes, a history of stroke, I guess a history of stroke can kind of go along with immobilization, meaning they weren't immobilized but they can't move maybe because of weakness due to the stroke. Parkinson's disease may be the same reason. HIV infection, I'm not sure why it's connected. I think it's a side effect of the medication that they take, not of the actual disease. And thyroid disease, so metabolic disorders that can change kind of the tissue metabolism, kind of like diabetes, can predispose to this condition. So this slide basically says that there's 3 phases to what you might see in the frozen shoulder. That it starts out with more pain, and then it progresses to more and more stiffness. Basically, in time, though, so basically this is an injury that tends to heal. So although there is scarring, thankfully there is in many cases healing that happens. The problem is that it takes a very long time, so you have to be patient. But I think in the majority of patients, after a prolonged period of time where their shoulder is very stiff, there is an ability to regain range of motion that was lost. And it's not always because of treatment. You know, there are some adjunctive treatments that you can use to facilitate, you know, improvement in the frozen shoulder, like physical therapy, corticosteroid injections. But there isn't actually evidence that that any one intervention actually heals it. It's really mostly just it heals with time. And for those who unfortunately don't heal, there are some surgical options. Okay. So that's it for the shoulder. Let's move on to the elbow. So let's talk about common causes of elbow pain. I listed here medial epicondylitis, or the way that it's more commonly known is golfer's elbow, lateral epicondylitis or tennis elbow, and then triceps tendinopathy and biceps tendinopathy. I'll address that shortly, but I'd like to focus on tennis elbow and golfer's elbow. So let's look at the anatomy again. So it's not as clear as I would like, but basically this is looking at the elbow from the back, and what I want to point out, this is the humerus bone, so that's the bottom part of the humerus bone, and it kind of divides into 2 sides, and we call those 2 sides the medial epicondyle and the lateral epicondyle. So I'll show you on myself. If you hold your hand out with the thumb pointing outwards, so in this position, the side that's closer to your body, that's called the medial side, and then the side that's on the outside of your body is called the lateral side. So the medial epicondyle is the prominence of the end of your humerus over here, and the lateral is the prominence over here. And the reason why those 2 bony prominences are important are that if you look at the anatomy of the forearm, so you have a group of muscles that are on top of your forearm that are functioning in wrist extensors. So they're the muscles that allow you to do this. And then you have a group of muscles that are at the bottom of your forearm, so over here, and those muscles allow you to do this, right? They allow you to flex your hips. So you have the wrist extensors and the wrist flexors. And anatomically, the wrist extensors attach this group. They all form kind of like a common tendon, and they attach at the lateral epicondyle, so here. And then the wrist flexors form a common tendon that attaches over here at the medial epicondyle. The triceps muscle, that's the muscle that runs down the back of your arm and helps you extend your elbow. And that muscle is seen here in this picture, and it attaches here at the back at a bony prominence called the olecranon process. So you see that a little bit better over here, and it's depicted here and here. So the triceps muscle attaches there, and then the biceps muscle runs along the front of your arm, and it attaches down here. So I just want to point out that those are 2 other tendons that can get a tendinopathy or a tendinitis. They can get swollen and inflamed, and all of these are common sources of, well, I would say the medial epicondylitis and lateral epicondylitis are common. The others are also possible sources of elbow pain. I wanted to point out olecranon bursitis. So this part of your elbow over here is called your olecranon process, and there's an area of soft tissue that's over the bony prominence. Any area of soft tissue over a bony prominence is called the bursa. A bursa is usually like a theoretical space. It's not an actual space, but it's kind of like a layer of tissue that's supposed to be a cushion between a bony prominence and the soft tissue that's overlying it. But that like small kind of cushiony theoretical, it's not a theoretical space, but it's a small kind of cushion space can also get inflamed, and when that happens we call that bursitis. And so the olecranon bursa over here, that's kind of, they're trying to depict that with that white circle. It's not quite that big in the body, but they're just trying to illustrate where it is. So that area can become inflamed as well. It causes a condition called olecranon bursitis, and in real life, you can, the bursa can swell so badly that you can get, like you see this picture over here, there's like almost a golf ball size swelling, and that's a result of the swelling and the inflammation of this bursa, and that's also a common condition. And then of course you can get osteoarthritis in the elbow, but it's not common actually to get osteoarthritis in the elbow. Okay, so we basically went over this slide. I just wanted to emphasize that this is the most common cause of elbow pain. Again, it can be caused by repetitive stress. Anything that you would do to repetitively extend your extend your wrist or flex your wrist, any kind of repetitive stress can pull at the bony insertion and cause a tendon injury. And cause a tendinitis. So basically tennis elbow and golfer's elbow are another tendinopathy. And the pain is usually is either felt at those bony prominences, or it could be felt like a little bit before it, in the belly of those muscles that are inserting, especially if there's like little tendon tears. So you can feel it like in those tendons or at the bony insertion. And it can really interfere with your activities of daily living that involve manipulating your wrist. So you typically feel the pain like in here for lateral epicondylitis, and in here for medial epicondylitis. So when I have patients with lateral and medial epicondylitis, I always tell them to purchase this brace. And as you can see, even though the epicondyle is up here, but this brace sits over like the main belly of the muscles that attach there, and by pressing on them, it gives them kind of like extra support, and it can help offload the tension on the tendon, and that tends to help. But in addition to the common approach to treating tendinopathies, which is ice, anti-inflammatory drugs, there's also bracing. And then for the long-term healing, it's also useful to do physical therapy, exercises to strengthen the muscles. And by strengthening the muscles, you can also kind of offload the tendon a bit. Most people recover from this with proper treatment within about, let's say, like 6 to 12 weeks. That's what I found in the literature. It sounds about right. Okay, so that's basically it for the elbow pain. Let's move on to hand and wrist pain. So the topics that I put for common causes of hand and wrist pain that I want to touch on are nerve entrapments. The most famous would be the carpal tunnel syndrome, which we'll talk about. Another tendinopathy, yet again, soft tissue problem. The most famous one in the hand would be called Decker-Gaines. Maybe you heard of it. Trigger finger is a very common complaint. Dupuytren's contracture, not as common, but it's very possible that someone in the audience either experienced or knows someone that has a Dupuytren's contracture. And osteoarthritis is common in the hand. There's 2 regions in the hand that are particularly affected. So since I don't want to talk about osteoarthritis, actually I'll get to some pictures later. We'll come back to it. All right, so let's talk about carpal tunnel syndrome. So in this picture, you're looking at a cross-section of the wrist, right here. And what you can see is the carpal bones. Those are the wrist bones. Going back to the last slide, for a minute. You can see the carpal bones. Having trouble with the pointer. These are the carpal bones. So these make up the wrist bones. Well, I mean, these bones articulate with the forearm bones, and they're called the carpal bones. And then what you can see is that all the flexor tendons that course from the forearm, we saw where the flexor tendons inserted on the elbow, but of course they continue and then they cross the wrist into the hand. All those flexor tendons go through this canal. That basically the basement of the canal is the carpal bones, and then the ceiling of the canal is this ligament over here called the transverse carpal ligament. It's like a tough band of tissue that kind of forms the ceiling to this canal. And through this tight space you have all these flexor tendons and then this nerve here called the median nerve. And they all have to share an apartment, so to speak. They all go through the same space. Now if anything happens to cause swelling in these tendons or swelling in the sheath that surrounds the tendons, or even if it's not in the carpal tunnel itself, but if you have like the lining of the wrist joint, the lining of the joint we call the synovium, if that's swollen, anything that kind of changes the architecture of this canal can basically cause compression of this nerve here called the median nerve. The median nerve has an important job. It gives sensation to the palm of the hand in this distribution. So you see where it's shaded here in darker. On the palmar surface of the hand, the palm, the thumb, and the first 2.5 fingers after the thumb are all fed or given sensation by the median nerve. So anything that causes compression of this nerve in the carpal tunnel can start to cause shooting pain into this region of the hand. And if it's very severe, it can actually, the pain can shoot backwards into the forearm as well. So basically carpal tunnel syndrome is an entrapment of this median nerve because of swelling within the carpal tunnel. So the symptoms could be just overt pain, or it could be more subtle, like just numbness, tingling in those fingers. It tends to be worse at night, probably because maybe while we sleep, we like sleep like this with our hand under our pillow, or we're, for whatever reason, flexing the wrist tends to cause more crowding and more compression within the carpal tunnel, and so the symptoms tend to be worse at night. And very classically, a patient will tell you, that they wake up in the middle of the night with hand numbness, and when they shake out their hands, they feel better, and that's kind of classic for early carpal tunnel syndrome. There is, I think, like a common, misconception that typing or like things like that cause carpal tunnel syndrome. I think that more like aggravates carpal tunnel syndrome than causes it. But basically, activities like driving, reading, typing, and holding a phone can make the symptoms worse as well. The median nerve can also give also gives motor input to your hand, so it also controls movement. So when carpal tunnel syndrome gets very severe, you can also lose strength in your fingers, and your grip can become weaker, but that's more advanced. The earlier, the less severe symptoms are just pain. So again, for this condition, there are some risk factors. It's more common in women, it's more common in people that are overweight, it's more common in diabetes, it's more common in rheumatoid arthritis. That goes back to the, rheumatoid arthritis causes swelling in the joint, so it goes back to things that cause compression. And it's more common in pregnancy. Not 100% sure why, maybe because of water retention can cause kind of more general swelling and compressive symptoms. So whereas some of those other syndromes that we talked about so far are more of a clinical diagnosis, in carpal tunnel syndrome we actually have tests that can kind of prove it. And the main tests are the nerve conduction studies, or EMG, with what we call. And a nerve conduction study basically can test how that nerve is conducting electricity, and if it's not, if the conduction is slow or abnormal, that can be indicative of carpal tunnel syndrome. And an EMG basically sees whether the muscles are receiving the signal from the nerve appropriately. And again, if there's inappropriate muscle activity, then it can implicate a dysfunction in the median nerve. All right, so how do you treat this? The most conservative way to treat this is to put your hand in a splint, which keeps your wrist in a neutral position, because again, like flexion of the wrist causes more compressive symptoms, and particularly at night, if you wear a splint that's like one depicted here, it keeps your wrist in a neutral position and can help relieve the compression. If that doesn't help, there's an option for steroid shots. And in the case where there is actual motor strength loss in the hand, so there are situations where you would just go straight for surgery. If a person actually has weakness in the muscles of the hand because the nerve is so entrapped and so affected, that's a reason for surgery. If you see that the muscles in the hand are wasted, they're not getting regular motor input, that's one of the reasons that you might opt for surgery. Or if conservative management and steroid shots and everything that you've tried don't alleviate the symptoms and they're debilitating, that's a reason for surgery. And basically, the surgeon will cut that ligament that we said forms the ceiling of the carpal tunnel and relieve the compression. Okay. I want to talk about Dequer veins tenosynovitis. So this is another tendinitis or tendinopathy, and this time we're looking at it's not projecting so well, but there's two muscles that come down along your thumb, down this side of your hand, and they basically control the motion of your thumb, moving your thumb away. And the names of those tendons are the abductor pollicis longus and the extensor pollicis brevis. It's these two tendons, these two muscles that come and attach here on your thumb joint. So when somebody has Dequer veins tenosynovitis, they usually complain about pain over here, and especially with the movement of their thumb. And again, the treatment approach is similar to other tendinopathies. It's bracing the tendon to offload it with a splint that would look something like this. It doesn't allow for this kind of motion of the thumb, and it gives it some rest. And then you can use, as usual, the anti-inflammatory medications, steroid injections, and in very severe cases, surgery. But generally, this is self-limited. Okay. Now I want to talk about trigger finger. This is another very common soft tissue injury that I think, certainly that I see, but I think many, probably Dr. Bright gets this complaint. I see this complaint maybe 3 times a week, sometimes twice a day. It's very, very common. So basically, what is a trigger finger? So the other name, or the more formal name for trigger finger, is stenosing flexor tenosynovitis. So again, we're talking about a problem with a tendon, a tenosynovitis. And the way a trigger finger presents is something like this. So I don't know if you can see it in the picture clearly, but basically a person will come in and say that they have really bad pain in the palm of their hand and that their finger locks. So they might, they might say that they're trying to open their finger, but it catches and it basically gets stuck, and they have to use their other hand to open their finger instead of being able to just extend their finger naturally. So what's going on? So over here you see these are the bones of a finger, and this can happen to any of the fingers in the hand. So these are the bones of the finger, and this is a flexor tendon coming up like this and attaching along the underside of the bones of the finger. And as you can see, the tendon is kind of held down to the bones of the finger with these pulleys, with these ligaments. And when you open and close your hand, that tendon is gliding. I mean, you can't really appreciate the gliding movement, but basically the tendon is gliding back and forth through these pulleys. And in order for there to be smooth movement of your fingers to open and close them, It needs to glide, oh, then that's fine. There needs to be smooth movement of this tendon within these pulleys. Now, in trigger finger, there ends up being a swelling over here at the A1 pulley. So that's the pulley that's like right over this part of your hand as the tendon is entering your finger. So this pulley gets inflamed, and then the tendon under it gets inflamed, and then the tendon can't move because there's inflammation and it can't glide back and forth, and so you can't flex and extend your fingers properly, and then they get stuck. So let's see. Basically, the symptoms are as I described. You'll feel a lot of pain, particularly when you're trying to open and close your fingers, and then you'll have this like catching, sticking, stuck situation going on with the fingers. So the way we approach this particular tendon problem is again with the brace, and you can see the kind of brace that we recommend over here. And like the other braces, what it's trying to do is provide rest for the affected tendon. It's trying to say, don't do this for a little while. I mean, it's a little bit hard to put up with, but it can be effective. And in addition, you want to avoid the repetitive motions that trigger it. You want to use non-steroidal anti-inflammatory drugs, and then you can use steroid injections. Steroid injections tend to be pretty effective for this problem. You give an injection right near the A1 pulley that's inflamed, and the steroids will calm down the inflammation, and usually 1 or 2 injections can be effective in alleviating the problem. And in refractory severe cases, you can also go on for surgery, but it's uncommon to need it. All right. This is a picture of a Dupuytren's contracture. I don't know if this is a problem that's familiar to you, but basically this is a disease of the palmar fascia, so the soft tissue that's surrounding the flexor tendons in the palm. Basically the fascia gets thick, it can form like nodules, and as it thickens and scars and form nodules, it kind of pulls the finger into flexion, and then it gets stuck there. But this is not a problem of the A1 pulley, this is a problem of the fascia in the palm over here. You could see like these nodules forming over the tendon, and then the finger, you just have this like, it's not so painful actually, but it's very disabling because the fingers get stuck with this kind of like thickened cord along the palm of the hand. We don't know why this happens. We think that there is a genetic component. It's more common in Northern Europeans. Other risk factors are age greater than 50, diabetes, cigarette smoking, and alcohol consumption. So there must be a metabolic component as well. Some relationship between genetics and metabolic dysfunction. Depending on how severe it is, some people remit on their own even without intervention. About 50% of people will progress, and you can use a combination of approaches of steroid injections or surgery. I wanted to touch on osteoarthritis of the hands just very briefly, just because it's such a common place to have osteoarthritis. Going back to, I just wanted to go back to the original anatomy of the hand. There we go. So the most classic places to get osteoarthritis in the hand are in this row of joints over here that we call the proximal interphalangeal joints, and then this row of joints up here we call the distal interphalangeal joints, and then down here at the very base of the thumb where the carpal bones articulate with this bone called the first metacarpal. So right here is also a very classic place to get osteoarthritis. Osteoarthritis just refers to degenerative changes in the joint, breakdown of cartilage, and then loss of joint space. So this picture shows you how osteoarthritis would look in the proximal interphalangeal joints and in the distal interphalangeal joints. You can see kind of like a bony enlargement and like a flexion deformity. This hurts a little. Most people say it hurts when they knock their fingers into something, or it can ache from time to time. It doesn't tend to hurt a lot, but it can hurt. And this is just what you might see in very severe cases on x-ray. You see kind of like a loss of joint space and deviation of the bones. All right, so now we're going to move down to the lower part of the body where we might be running low on time, so we'll cover as much as we can. I want to leave a little time for questions. So some common causes of a lot of times people will come and say that they have hip pain. Hip pain is like really like a catch-all expression on the part of the patient that can really mean any kind of pelvic girdle pain, because people will call buttock pain, hip pain, lateral hip pain, groin pain, hip pain. So hip pain can mean a lot of different things, and these are some of the common causes. So if the pathology is actually in the hip joint, it could be from a labral tear. So just like the shoulder joint had a labrum, so does the hip, and there could be a labral tear there. It could be from impingement, which I won't go into too much, but basically it means that the hip joint kind of gets stuck. When the hip moves, it kind of gets stuck over under the rim over here. Like if this rim over here is a little bit big, or there's some, if the anatomy is a little bit wrong, so you can get impingement there, and that can cause pain. You can have osteoarthritis in the hip, that's very common. Those are probably the three most important causes of the true hip joint pain. But then other pain in like the buttock and then the back of your leg area can be radicular pain, which is basically nerve compression, and the most famous example of that is sciatica. And then there's something called greater trochanteric pain syndrome that used to be known as trochanteric bursitis, which I want to touch on because that's very common. So let's see if there's any. So let's talk about sciatica. So sciatica is basically a nerve compression. Another name for it is a lumbosacral radiculopathy. And basically it means, so if you look at this picture, you can see this is a picture of the spine, and these are vertebrae in the spine. And the spinal cord runs here, and it gives branches. And these branches run out of the openings in the side of like between the spinal bones. So when anything that happens in this region to cause compression on these nerves can cause nerve pain. And in sciatica, the sciatic nerve can be affected kind of like anywhere from here and downward if it's compressed somewhere in the pelvis. And what the person is going to feel is pain, numbness, or tingling either in the buttocks or down the back of the legs. So what causes these nerve compressions? So two common causes are formation of bone spurs in the vertebrae. So if you get degenerative arthritis in the vertebrae and little bone spurs form here, they can either impinge on the canal, or they can impinge on these little openings called foramen, and those bone spurs can impinge and cause nerve entrapment. Or these discs that are in between the vertebrae, they can kind of herniate backwards. They can get squeezed and bulge backwards, and as those nerves come out, those discs can compress the nerves. So those are sort of, you can have underlying degenerative changes in the spine that lead to nerve compression that can lead to hip girdle pain. There are some additional risk factors like diabetes or any like infection, inflammation situation in the spinal cord or within the hip girdle area can cause these compressive symptoms. Treatment for sciatica or other nerves that come out of the lumbosacral spine that are impinged are basically pain medications like we discussed, physical therapy, steroid injections, and in very severe cases, surgery to alleviate the compression. Now let's touch on greater trochanteric pain syndrome. So here you're looking at one side of the pelvis, and this is the hip joint, this is the femur bone, this is where the femur articulates with the pelvis. And then you can see that there's a lot of buttock muscles going on here. And muscles come, this is looking at the buttocks from the back, you can see that these muscles come and attach at the side of the femur over here. So these are a bunch of muscles coming from the back, these are the tendons, and this is their site of attachment on the femur. And that corresponds in our bodies to right here, like the lateral hip. So a lot of people who complain of pain will come and basically say my hip hurts and they point over here, and very commonly it's because of greater trochanteric pain syndrome. So what's going on in greater trochanteric pain syndrome? Basically, we talked about bursas before. So bursas are those spaces over bony prominences. So this bony prominence here, where are we? This bony prominence here on the femur bone is called the greater trochanter, and that's a place where a lot of buttock tendons insert. And so between where those tendons insert on the bony prominence, you have these spaces called bursas that are those cushions that can get inflamed. So in greater trochanteric pain syndrome, all of these, basically the inflammation is in these tendons and in these bursas. The bursas are depicted in like these blue bubbles. They're not quite that big in real life. They're just trying to like demonstrate where the bursas would be. But in greater trochanteric pain syndrome, this is the area of pathology. Everything that inserts on the greater trochanter can become inflamed. It can just be like a swelling, or it could be micro tears. So basically, a person will complain about lateral hip pain, and another common complaint is that they have trouble sleeping on their side at night. Like when they want to roll on their side and curl up on one particular side, lying on that bony prominence can really hurt. They also can have pain with walking, particularly when they're extending their legs during the gait cycle, and it can be disabling. So some of the risk factors for this are basically anything that alters the mechanics of your gait. So having any other pathology in the pelvis, like hip osteoarthritis, knee osteoarthritis, or even lower, plantar fasciitis, anything that's going wrong within the pelvis or the lower extremities to alter the way you walk and changes the mechanics of the way you walk, can cause those tendons to have extra strain on them and those bursas to become inflamed, leading to the symptoms. Treatment is similar to other tendinopathies, again NSAIDs, again ice, again steroid injections, which can be very effective. I do that a lot in my practice and I have good results. Physical therapy, depending on how much it's aggravating, and then also in this case, trying to correct any underlying cause to the gait dysfunction. So if it's plantar fasciitis, to treat it. If it's knee osteoarthritis, if possible, to treat it. So looking for underlying causes and correcting it can also help. Losing weight. If this doesn't improve with conservative management, then you might send a patient for imaging to see if it's just tendinopathy and bursitis, or is there actually a tear in those tendons, because in the case of a tear you might want to opt for surgery. Okay, so very quickly I'll touch on knee pain. This is the anatomy of the knee. This is the kneecap. This is your tibia, fibula, your femur, and this is the joint. So the important structures that can cause knee pain, other than osteoarthritis, which is probably the most common, is any damage to any of these ligaments. So you have the lateral collateral ligament that connects the bone, these two bones over here. You have the medial collateral ligament that connects the bones over here. You have the anterior cruciate ligament and the posterior cruciate ligament that connects the bones from the middle. Any strain or tear to those structures can cause knee pain, and also it can cause knee instability. In addition, you have a layer of tissue that doesn't really show so well, but it's basically like a cushion between the femur and the tibia, and they're called the menisci. So you have two. You have the medial meniscus over here and the lateral meniscus. Any tear to that soft tissue structure can cause knee pain or knee instability. So basically, there's a lot of different ligaments in the knee that strain of any of them can cause pain. I'm also going to point out the quadriceps muscle here and the quadriceps tendon that attaches to the patella. That can get strained and torn, and then the patellar tendon can get strained or torn. So any of these structures can cause injury to these tendons, or ligaments can cause pain. You can also get bursitis in your knee. There's two common ones. There's prepatellar bursitis and there's pes-anserine bursitis. So you have a bursa over this bony prominence, the kneecap, that can get inflamed and cause bursitis in the knee. It most commonly happens in people who kneel on their knees a lot. So people who, let's say, clean floors and are kneeling on their knees, or people who pray on their knees, they're at risk for prepatellar bursitis. And then another common type of knee bursitis that's important to know about is anserine bursitis. So over here, this is the tibia, the lower leg bone. There are, I don't know if I have a better picture. I don't think I have a better picture, but basically there are three muscles three basically like hamstring and adductor muscles that come over here down from the back, and then they attach on this section of the tibia. And where those tendons, where that group of three muscles attach, there's another bursa, that cushion between the tendon attachment and the bony prominence, and that bursa can become inflamed. And that can lead to bursitis. And I think that's important to know because a lot of times when people complain of knee pain, there's an assumption that it's osteoarthritis or some kind of ligamentous sprain. But this shouldn't be forgotten, and it can be easily distinguished from other causes of knee pain because it's not really in the knee joint. It's lower down than the knee joint, over the tibia, the medial tibia, over that bony prominence, and you can elicit it by touching it or seeing the swelling, and it's easily treated with steroid injections. So I just wanted to bring that to your attention. I'm not going to talk too much about ankle pain because it usually involves sprain of 1 million ligaments that cross the ankle. It's not a common place for osteoarthritis, so let's just leave it at that. And then foot pain, I just want to mostly focus on plantar fasciitis because that's a common soft tissue problem. So basically, this is the plantar fascia. It's a strong band of tissue that extends from the heel to the toe bones, and its function is to provide support as the toes bear the body's weight when the heel rises during walking. This soft tissue can become inflamed, and particularly in this region, and people will complain about pain under their heel or pain right in front of their heel in this spot over here. So another kind of classic complaint when it comes to plantar fasciitis is that people complain that their foot, that it hurts at the bottom of their foot when they first get up in the morning and first put their foot on the ground. That's kind of like a classic plantar fasciitis presentation. So the causes are basically anything that would make you, get up on your toes over and over again. So running, marching, dancing, but it doesn't, you don't have to be a runner in order to get this. This is a common problem that many people have. Here are a list of some of the other risk factors: improper running shoes, running on very unyielding surfaces, so like running on concrete with bad shoes can do it. And then different, changes in the anatomy of your foot, like having high arches or flat feet, can also be a risk factor. The treatment is similar to other soft tissue treatment: rest, ice, steroid injections, trying to avoid provocative activities. There is a splint for this as well. It's like a rigid boot that you can be fitted with and that you wear at night. It's just very hard to comply with because it gets pretty uncomfortable having your foot in a rigid boot all night, but it can help. And then second line treatment would be like a walking cast. Shockwave therapy is controversial, and then like the other soft tissue complaint, surgery. So that's what I want to cover as far as common soft tissue problems, and I'm happy to take any questions.